everyone, welcome to our discussion on cross-matching. So this will be the second to the last activity that we are going to tackle in MD36. Introduction to this topic, the primary objective of your cross-matching is to detect the presence of antibodies that are present in the recipient's serum, including anti-A and anti-B that could destroy transfused RBCs or the blood coming from the donor. Traditionally, cross-matching means testing of the patient's serum with the donor's red blood cells, and this includes an antiglobulin phase or simply an immediate spin phase to confirm ABO compatibility. So take note, guys, that the terms compatibility test and cross-match are sometimes used interchangeably, but they should be clearly differentiated because a cross-match is only one part of the pre-transfusion testing or compatibility testing together with ABO group and RH typing and also screening for any unexpected antibodies. Main functions of the serologic cross-match. The first one is it serves as a final check of your ABO compatibility between donor and patient. And second, it may detect the presence of an antibody in the patient's serum that will react with the antigens on the donor's red blood cells, but that was not detected in the antibody screening because the corresponding antigen was lacking from the screening cell. So the second bullet, you will understand more about this one when we go to antibody screening and identification, which will be our last activity for this semester. So again, sometimes even if your patient or the recipient and the donor are both compatible because they have the same blood type, there could still be transfusion reactions that might happen after transfusion because before the blood was transfused, there were lacking screening cells in the antibody panel that was not tested. So probably if magka-transfusion reaction man gani, it was because of that certain screening cell that was not tested during the antibody screening. Okay, so before we proceed to the discussion of the different types of cross-matching, let's first talk about the specimen requirements for this test. So we can actually use either anticoagulated samples or clotted specimens for cross-matching. Either of these two types of samples are acceptable for the procedure. But between the two, it is the anticoagulated sample or specimen that is often preferred or recommended due to the ease of handling. Another thing is that red blood cells coming from our anticoagulated samples are ideal for the preparation of our red cell suspension for the testing. And aside from that, it's not only cross-matching that makes use of the red cell suspension, but other laboratory tests that are also performed in the blood banking section, like your tests for antigen antibodies. We also have ABO grouping and RH typing. Those procedures also make use of the RCS. Okay? Take note, guys, that the use of your anticoagulated sample or the sample collected using the lavender or purple top tube, there is always a possibility for the inactivation of complement binding antibodies due to calcium chelation, which can disrupt the complement cascade. But you have to remember that the benefits of using the anticoagulated sample or specimen outweigh this potential risk. Okay, so that is for the anticoagulated specimen as a sample for cross-matching. So we can also make use of clotted red blood cells, no, or samples collected using the red top tube for cross-matching. But of course, we have to make sure to properly wash our clotted red blood cells, or additional washing steps may be incorporated in the preparation of the sample. Okay, of course, normal saline solution is still the best washing solution, no, to do this one, to wash um, our sample or specimen. Okay, now why do we need to wash our clotted specimen, it's because our serum may contain small fibrin clots that can be difficult to distinguish from true agglutination. Okay. Next, we have IV line contamination is unacceptable and hemolyzed specimen must be avoided. So these are also precautions that we need to be aware of when we are going to collect samples from our patients who will, be tested for cross-matching. So with regards to the IV line contamination, IV contaminants, no, from the infusion fluid may dilute otherwise detectable antibodies in the specimen and may produce erroneous results. So, in the event that the inpatient only has one IV line, let's say either in the left or in the right arm, we have to collect the specimen from the arm opposite the IV catheter and never above it. But of course, there will be instances wherein our patient will have both IV lines, no? Will have IV lines in both arms. Uh, in the left arm or in the right arm. So if this is the situation, the best thing to do is, of course, ask permission from the nurse to turn off the IV drip first before you collect the specimen. And you have to incorporate collecting the discard tube, no, prior to the collection of the main sample to be used for the cross-matching procedure. So if venous access is limited and and you have no other choice but to, collect the specimen from the IV line, the infusion fluid must be stopped and the line must be flushed. Okay. So, with regards to hemolyzed specimen, no, hemolyzed specimen can mask antigen antibody mediated hemolysis and, of course, create difficulties in evaluating test results. So, of course, this is, I think, a very common protocol not only in cross-matching but other tests also performed inside the laboratory that hemolyzed specimen must be um, discarded. Okay, it must not be used to determine certain levels of analytes in the patient's body. So any specimen that shows hemolysis, it must be discarded, and of course the phlebotomist must collect the sample again. Okay, and then we have here pre-transfusion specimens and donor unit segments are typically stored at 2 to 8 degrees Celsius, that's refrigerator temperature, and must be retained in the event that additional testing is warranted. So, guys, after you have, for example, in your future profession, when you will be working inside laboratory and you are assigned in a blood banking section, and of course, you will be exposed to how cross-matching procedures are done. Um, Please do not discard your samples immediately after processing, especially for samples that came from your donor and the recipient. Okay, the reason for that is um, in situations wherein there will be unexpected transfusion reactions, the specimens of both your donor and the recipient are just there and you don't have to collect again. So in order to investigate the problem, you will already have the specimen stored inside the refrigerator. So the patient sample and a segment from the donor unit must be retained post-transfusion. That means after the transfusion took place for at least 7 days. No, this allows for the investigation of any adverse events related to the transfusion, such as a delayed hemolytic transfusion reaction. So, after 7 days, if there are no transfusion reactions that happened in your recipient, then it's safe to discard the segments and the samples from your donors and your recipients. We go to the two types of cross-matching. So the first type is the major cross-match, which involves the patient's serum or plasma plus the donor's red cell suspension or red blood cells. And we have the minor cross-match, which involves your donor's serum or plasma plus the patient's red cell suspension. So for easy memorization, for easy understanding, just take note of these acronyms. For the major cross-match, you have your PSDR, PS means patient serum and DR means donor's red cells. And for the minor cross-match, we have the PRDS or patient's red cells plus the donor's serum or plasma. Cross-matching has three phases. These are your immediate spin, or otherwise known as the albumin protein phase or the room temperature phase. Then second, we have the 37 degrees Celsius phase, or known as the thermophase or the incubation phase. And lastly, we have the AHG or the Coombs phase. For the immediate spin phase, so this is the first phase for your cross-matching. This involves testing the patient's blood sample for ABO, RH, and other clinically significant unexpected antibodies. And we can accomplish this phase by mixing the recipient serum with the donor's red blood cells, and we have to centrifuge the samples immediately. So the absence of hemolysis and agglutination indicates ABO compatibility. So if your sample during the immediate spin phase would not show any hemolysis or agglutination, you have to proceed to the second phase for cross-matching. Here are some advantages of performing the immediate spin phase. So the type on screen coupled with an immediate spin cross-match shows that it is a safe and effective method of pre-transfusion testing, and it has been calculated to be 99.9% effective in preventing occurrence of an incompatible transfusion, especially in patients with hyperimmune ABO antibodies. A person exposed to a specific immunizing event may produce immune ABO antibodies of the same specificity as a naturally occurring antibody but with different biological behavior. Examples of immunizing events that may produce these hyperimmune ABO antibodies include pregnancy with an ABO incompatible fetus or transfusion of ABO incompatible red blood cells. After immunization, the subject's antibody may increase in titer and or avidity, develop powerful hemolyzing properties, or become more active at 37 degrees Celsius. Also, it your immediate spin phase, it's also effective in preventing occurrence of an incompatible transfusion, especially in procedures not performed correctly. If there is delay in the centrifugation process or a delay in the reading of the results. Also, it is effective when there is rouleau formation that is observed and when using infant specimen during testing. The disadvantages of IS phase, on the other hand, are the following. The immediate spin does not detect all ABO incompatibilities, and sometimes it's prone to false reaction. So this is seen in the presence of other immediate spin reactive antibodies. Now, what are the possible reasons for incompatibilities in the immediate spin cross-match? So first one, we have incorrect ABO grouping of recipient or of donor unit selected. So when this happens, you have to repeat ABO grouping of the recipient specimen and confirm it with a new specimen if necessary. So you have to verify the donor unit if the donor unit is ABO compatible with the recipient, and repeat donor confirmation testing if necessary also. Second reason for incompatibilities in the IS phase, you have presence of cold reactive allo or autoantibodies in the plasma not detected in antibody detection test. So if the antibody screen was negative, we have to perform antibody identification at room temp since the incompatibility is detectable at that phase of testing. So you have to include an autocontrol to distinguish between a cold reactive allo antibody versus autoantibody. So the autocontrol will tell you if an autoantibody is present, because if the results in the autocontrol are positive, then most likely an autoantibody is present or the antibody coming from the recipient. But if an allo antibody is present, the autocontrol will be negative. Okay, and then aside from that one, we have to pre-warm no the test system. Uh, to circumvent the reactivity in the presence of a cold reactive antibody, we have to select donor units based upon the antibody identified and the clinical significance assessment. So depending upon the recipient's blood type, it may be useful to include no A1, A2, and B cells. By the way, the A1 and A2, these are subgroups of A when testing the plasma to rule out the presence of immune-mediated or possibly acquired ABO antibodies. So a thorough stem cell or solid organ transplantation history may be helpful in resolving this type of discrepancy. And lastly, last reason for incompatibilities in the IS phase would be abnormalities in the recipient's plasma. So the rouleau formation or the stacking of our red blood cells that is actually brought about by abnormalities in our plasma. So rouleau mimics agglutination and it may be present in diseases such as your multiple myeloma, no, so Rulu is detectable only when plasma is present. So we have to perform saline replacement and repeat the immediate spin cross match. The saline replacement technique involves removing the plasma from the IS cross match and replacing it with saline. Rulu will disappear while true agglutination will not. So basically that is the difference between the two, between Rulu formation and a true agglutination when performing saline replacement or saline replacement, no, because in the presence of your saline or NSS, um rouleau formation will be dispersed while true agglutination will stay as it is. Now after you have performed the first phase of the cross matching and you have observed that there is no agglutination or no hemolysis. That means that in the first phase of the cross matching, your recipient and donor are both compatible. So you have to proceed to the next step or the next phase. So the next phase is what we call the incubation phase. So this one includes the addition of potentiators such as your LISS or low ionic strength saline, your BSA, or your bovine serum albumin and the like. So this is done to detect clinically significant antibodies, especially antibodies that are reactive at 37 degrees Celsius. So the test system is incubated at 37 degrees Celsius using the water bath and completed with the antiglobulin test. But of course, you only have to proceed to the third phase or the antiglobulin phase if in the second phase there is also no hemolysis or agglutination that was observed. The third and final step of our cross matching is what we call the AHG phase or the Coombs phase. So in this step, it begins in the same manner as the IS phase and continues to a 37 degrees Celsius incubation and finishes with an antiglobulin test. So remember your antiglobulin test that after you have placed your sample inside a water bath at 37 degrees Celsius, you have to take out the tube and then you have to wash your sample with normal saline solution 3 times before you add your Coombs reagent or the AHG reagent. So for greater sensitivity, an anti-human globulin reagent containing both your anti-IgG and anti-complement may be selected for the final phase of our cross-match method. So if your AHG reagent contains both your anti-antibody and your anti-complement. So that means that this is a polyspecific AHG reagent. So now we go to the resolution of incompatibilities in the serologic cross-match. So always remember guys that a positive result in the cross-matching test would always mean that it would require an explanation, because there should be no agglutination or hemolysis that must be observed if your recipient and donor are both compatible. Okay, the recipient should not receive a transfusion until the cause of the incompatibility has been determined, and the results of the autocontrol and antibody screening tests should be reviewed to identify patterns that may help determine the cause of the problem. So prior to blood transfusion of the recipient, the medical technologists will have to make sure that all phases of the cross-matching test that was done should be compatible. Okay, because if in the first phase there's already the presence of any agglutination or hemolysis for that matter, the cross-matching test must be stopped. Okay? Because that would only mean na dili sila compatible with each other. But if the cross-matching test would proceed to the second phase until it would reach the third phase and there is still no agglutination or hemolysis that will be observed in the tube, then of course that would only mean that your donor and recipient are compatible. But take note, guys, that sometimes, especially in the antibody screening and identification, if you have listened earlier, that even if your donor and recipient are compatible, there is still a possibility of transfusion reactions, post transfusion reactions, or while the transfusion of the blood component is ongoing, the recipient might still experience reactions because of the absence of the screening cell in the panel. Okay, so kato siya na specific screening cell was not tested. So that could be the reason why there is a reaction of the donor's red blood cells and the recipient. So what are the causes of positive results in the serologic cross-match? So these are the following causes. First, incorrect ABO grouping of the patient or donor. So I think this is already the job of the medical technologist to be able to correctly perform the ABO and RH typing properly. Okay, so you have to determine or you have to practice the skill of determining the positive or negative reaction when performing for the slide method, or if the ABO or RH typing is done using the tube method, you should be able to learn how to grade your agglutinations properly or how to describe hemolysis properly. Okay, next, an alloantibody in the patient's serum reacting with the corresponding antigen on donor's red blood cells. Okay, so when we see alloantibody, again, that is the antibody that comes from the sample of another person. So if that was introduced to you, that is an alloantibody. That is different from the autoantibody because the autoantibody is the antibody produced by your own body and it reacts against your own antibodies. Okay? And then an autoantibody in the patient's serum reacting with the corresponding antigen on donor's red blood cells, prior coating of the donor's red blood cells with protein resulting in a positive anti-human globulin test. Okay? And lastly, abnormalities in the patient's serum, especially for individuals who have let's say multiple myeloma or increased amounts of proteins in the serum that would cause for a positive result in the serological cross-match. For the procedure of our cross-matching test, so take note that there are three phases involved in performing cross-matching. So we start first with the immediate spin phase. It's otherwise known as your protein, albumin, or the room temperature phase. Okay, so generally for the entire procedure, we have to prepare two clean test tubes and then we have to label one test tube as M, signifying that that tube is for the major cross-matching, and the other tube will be labeled as N for the minor cross-matching. So we just have to follow the table shown on this slide on what are the components to be added per tube. So for example, in your tube labeled as M for the major cross-matching, you will be adding 2 drops of your patient's serum and then 1 drop of your 5% red cell suspension, which is from the donor, and also add 2 drops of your LISS. So basically for the LISS, which is a potentiator, this is optional. Okay, for the minor cross-matching tube, you will be adding 2 drops of your donor serum, and then we have 1 drop of our 5% red cell suspension coming from our patient or the recipient, and also optional 2 drops of your LISS. Now, after we have completely added all the necessary components for each tube for the major and minor cross-matching, we have to cover our test tubes with Nasco film and then mix the contents by agitation. Now, we have to load these test tubes inside a centrifuge for spinning for 15 seconds at 3,400 RPM. After you have placed your tubes inside the centrifuge, you have to interpret first the hemolysis followed by the agglutination. So gently remove the tubes from the centrifuge and properly interpret the hemolysis result as either NH, pH, or CH. And then after that one, you have to dislodge by agitating the test tubes. Dislodge the cell button that have formed at the bottom of the test tube and properly grade for the agglutination. So if there is no agglutination or hemolysis observed, you have to proceed to the next phase. And if otherwise, meaning to say if you have observed either hemolysis or agglutination, you have to stop at this phase. Alright, so if there are no hemolysis and agglutination observed in the first phase of our cross-matching, we have to proceed to the second phase. So of course, the second phase is your thermo or the incubation phase, meaning to say that we have to place our test tubes inside a water bath set at 37 degrees Celsius. So for tubes showing no agglutination or hemolysis, we have to incubate them for 10 minutes at 37 degrees Celsius inside the water bath. After 10 minutes, we have to centrifuge again our test tubes for 15 seconds at 3,400 RPM. And then, like in the first phase, we also have to properly interpret the hemolysis result as well as properly give the agglutination grade. So if there is no agglutination or hemolysis observed in the second phase of our cross-matching, then we will be proceeding to the third and last phase of these tests, which is also known as your AHG phase. So if either hemolysis or agglutination is observed in the second phase, you have to stop at this point. Okay, so granting that in the second phase there was no hemolysis observed and there was no agglutination observed also, or you were able to give a grade of 0 in the agglutination, then most likely your tube will proceed to the third phase, which is your anti-human globulin phase or the Coombs phase. So for this one, um, you have to wash your cells or the tubes, no, wash the tube showing no agglutination or hemolysis with NSS 3 times. Basically, guys, the AHG phase or the Coombs phase is the same with your indirect anti-human globulin testing na procedure. Okay? And then after that one, after the third washing, no, you have to properly remove or completely remove all the NSS present in the test tube. Take note, the manner of doing that is by decanting um, the contents of the test tube and then blotting dry the mouth of the test tube on the final washing. After that one, add 2 drops of our AHG reagent and then centrifuge the tube for 15 seconds at 3,400 RPM. And then we have to observe for the hemolysis and then dislodge the cell button to give an agglutination grade. So we have to properly grade our reaction for this phase also. For the interpretation of our cross-matching results, no, there are only 2 ways of interpreting the results. It could either be compatible or incompatible. So, of course, for compatible na interpretation, that would mean that there is no agglutination or hemolysis observed in all phases of the cross-matching test. Incompatible, on the other hand, that means presence of either agglutination or hemolysis in any tube in any phases of the cross-matching test. Okay, so we have here a guide in the interpretation of our cross-matching results. So take note again that these tests involves three important phases. So we have the protein phase or the immediate spin phase, then we have the thermo or the incubation phase, and lastly we have the AHG phase. So as you can remember in earlier discussions, we have to prepare two test tubes for this test labeled as your major cross-matching tube for M and the minor cross-matching tube, which is labeled as N. So um, the results that you can see on this table, the zero here indicates negative or absence of hemolysis or negative for agglutination, or the grading is zero, whereas the positive here would indicate presence of hemolysis or agglutination. Okay, so case 1 here, it shows that in all phases of the major and minor cross-matching from protein phase until the last phase, which is AHG, the tubes did not show any hemolysis or agglutination as indicated by zero. Okay, so of course, the interpretation for that is we would really know that our recipient is very compatible with our donor. So blood is compatible both in major and minor cross-matching. That's why blood is safe for transfusion. Okay, so no problem for case 1 because we said that compatibility can only be determined if there is no hemolysis or agglutination observed in all phases of our cross-matching test. Okay, for case 2, okay, in case 2, for the major cross-matching, you can see here that in the first phase, no, in the immediate spin phase, there is already the presence probably either of hemolysis or agglutination. Whereas for the minor cross-matching in all phases, there is no hemolysis or agglutination observed as indicated by zero. So the interpretation for this one is blood is incompatible in major cross-matching but compatible in minor cross-matching. Specifically, in all phases of the minor cross-matching, it's compatible. So blood is not safe for transfusion. Okay, so even if um, no hemolysis or agglutination is observed in the minor cross-matching tube in all phases, but in the first phase mismo, it's already positive for either hemolysis or agglutination, especially that it is a major cross-matching, then automatically blood is not safe for transfusion. Okay, for case 3, we have here results of the major and minor cross-matching. So we can see that in the first phase, both the major and minor cross-matching procedures already showed positive results, probably either for hemolysis or agglutination. So with that, it is understandable now that blood is incompatible both in major and minor cross-matching. That's why it's not safe for transfusion. Okay, and the last case that we have here is that um, for the major cross-matching from protein phase or immediate spin phase until the AHG phase, the tubes did not show either hemolysis or agglutination, but in the first phase for the minor cross-matching, the tube showed either hemolysis or agglutination. So for this one, we can say that blood is compatible, but we have to transfuse the blood with caution. Okay, so this usually happens in rare cases wherein blood can be transfused but with caution, no? As in, like, rare cases lang ni siya because we have to bear in mind that we have to make sure that the donor and the recipient are really compatible with each other in terms of the blood type and also the blood components to be transfused to the recipient. Okay, so for this one, if there is positive result in the minor cross matching starting from the first phase, um, yes, blood can still be transfused, but we have to be wary, okay? We have to be very careful, and we really have to observe our recipient when he or she receives the component, okay? There could be a possibility for this patient to suffer from transfusion reactions while ongoing ang blood transfusion. That will be all for our lecture about cross-matching test. So thank you so much for listening and have a good day.